Today we're going to talk about vein disease. And you may wonder, why does that fall into what you do? Well, the reason is because we use a lot of ultrasound, and I'll explain that later. But we use ultrasound and little catheters and wires to get where we need to go. And because of that, it really falls in the category of what interventional radiologists do. Do I treat fibroids as well, and back fractures, as I said, and blood vessels? Yes. So I'm a kind of a plumber and a photographer, essentially, in the medical field. Okay? Make sense? So here we go. Does this look familiar to you? You know a lot of people that look like this? Here's a bunch of blood vessels that are abnormal, pooling down here. I'm going to show you a couple examples just to get your eye used to what we're talking about. Today's topic will be treatment of superficial vein disease, and I'll explain the difference between a superficial vein problem and a deep vein problem, okay? Both of the legs. So here's more veins that are abnormal, you can see here. And here, this is a lovely young person. She happens to be a hairdresser and didn't expect at the age of 30 to be feeling so much pain and heaviness and discomfort in her legs, but indeed, this is what her legs look like. Now, is it normal for a 30-something-year-old person to have this sort of discoloration? This sort of pooling? No. You can tell before I even do the ultrasound that indeed this person is going to have vein disease. And indeed, though cosmetically she wanted it improved, it's really, as a hairdresser, you can imagine, she's standing all day long. Her legs were aching and cramping and hurting, and all she wanted to do was elevate her legs at the end of the day. And that's one of the main symptoms of vein disease, when you just have that feeling that you want to elevate your legs at the end of the day. That is a superficial vein, a varicosity that's running in the pretibial area. And here again, we're seeing the brown staining that is just classic for superficial vein disease. How about these varicosities? So today what we're going to do is we're going to do an overview. I'm going to explain to you a bit about vein disease. We'll go over the anatomy, the etiology, the testing, treatment options, complications, and follow-up. And I'm going to be pretty detailed with you. I'll be happy to answer questions, and I will be sure to leave time at the end for you to ask as many as you'd like. And even during the lecture, I'll be stopping at various points, so you don't have to remember for 45 minutes or an hour, okay? Do you have questions to this point? No? We're okay? All right, so here we go. So who gets varicose veins? Well, 25% of women and 15% of men.
Excuse me,
I'm in the way, aren't I?
Yes.
Here we go. Can you see there? Better?
Yes.
I'll stand to this side. No, now you can't see on that side. Let's see. Sarah, you know what I think we need to do? Where's Sarah? I'm going to move this. You're okay. All right, is that better? Can you still see? All right, so we'll keep going. So you inherit this disease. There's an abnormality in the collagen and the elastin of the vein. People think that if you're just a big size or you stand all day, you're going to get these veins, but that is not the case. You really do inherit it most of the time. So what does that mean? That means if two parents have it, you have a 90% chance of having it. If one parent has it, you have about a 60% chance of having it. And if neither parent have it, well, you're the lucky one, you got it, and about 20% of the time, you will have it as well. Do pregnancy, obesity, all these things play a role? Absolutely. But they are not nearly as important as genes. So a variety of thin people, never been pregnant people, etc., will have this disease. And as you can tell, it's extremely common. We call it a vein disorder because actually it's that common. It's not really a disease, but it is a disorder of your veins. And when it gets bad enough, and I'll show you how we classify things, we then call it venous insufficiency, and we give it even more significant titles. Make sense? Okay. So 4.5% of 12 million people in the US are affected by this, and it increases with age, it increases with the number of pregnancies you have, and 40% of women in their 50s suffer from some sort of venous disorder. So, number one symptom, if you're going to have symptoms, is this aching, heavy feeling. Why? Gravity is working against you in the veins, right? The head, the neck, if you had a vein problem, it would just drain nicely into your heart and your lungs. But if you think about veins, they are fighting against gravity to get that blood back up to the heart. So I showed you the picture of the woman with the legs and the veins in the inside of the ankles. Why do we see it there? That's the bottom point. That's where gravity has pulled all the blood. Okay? So that's where we tend to see it first. You can get swelling. It really is venous veins, hypertension, too much pressure in those pipes. You turn a hose on, you know that pressure that's coming at you instead of a nice dribble? Well, because the valves aren't working, you have too much pressure in those veins pushing on the lower leg veins, and you get problems. You get pain, you get distension, the valves don't close, and the veins that are feeding them, we call them the tributary branches, they get big and dilated too. The skin over the vein can become dry. We call it venous eczema, venous stasis. The skin is not used to having the hose turned on, basically, and pushing all this venous blood into the skin. So you can have a lot of dermatologic abnormalities from the vein disease. You can also get an inflammatory response where your body is just not happy, and so actually you can break down, you can get an ulcer, you can get an oozing ulcer, or you can get this bark-like hard skin in the area. Restless leg syndrome is sometimes associated with having venous insufficiency as well. Too much blood in the legs can give you restless leg syndrome. So here's a nice example of abnormal veins. You can see the tortuosity in the vein. Do you see this here? And this is what happens. The vein just becomes twisted instead of being nice. And I said the valves don't close, the vein dilates, and the valve doesn't close. So the blood tries to get back to the heart, but instead it's going the wrong direction, and it is going towards the leg. This is a classic example of too many veins in the inside of the calf communicating with a refluxing great saphenous vein. Now when you leave here today, I want you to remember two veins, the one that runs in the inside of your leg called the great saphenous vein, and the one that runs behind your calf called the small saphenous vein. And this is an example of reflux in the great saphenous vein producing varicose veins in the inner medial calf. So how important is it to walk? It's very important, okay? As you walk, your calf contracts and you push blood from the lower leg veins up towards the heart. Now your veins have valves and they catch the blood, so the blood does not go in the wrong direction back down towards your feet. Your arteries are different, right? Your heart contracts and the artery blood goes towards your toes. You don't need valves. They're going that direction and gravity is pulling it and it's all good, no valves. But when you're coming back against gravity, your calf contracts, the blood migrates up, the valves close, and that's what holds the blood from going back in the wrong direction. But if you have this disorder of the vein, your collagen, your elastin, the things in the wall of the vein and the valve of the vein are abnormal, the vein will begin to dilate. And as the vein dilates, the valves won't close. And the valves themselves, everything is abnormal. And so the blood is now going in the wrong direction. So walking is extremely important and does help with vein disease. Now this is a nice picture because it shows you what you're seeing. If you look at your legs and you see these teeny little spider veins, I like to call them the ends of the branches of a tree. Okay? You're seeing the teeny little branches at the end, but they're coming from somewhere and they're communicating with deeper branches called reticular veins and then varicose veins, and they even are communicating with the deep veins. And the blood should be going this direction towards the deep veins. But when you have reflux, the blood is going in the wrong direction towards these superficial veins. Does that make sense? So this is what you see, but there's a whole bunch of stuff happening under there as well. Okay? We call them, this is a bit of terminology for you, but this would be called varicose veins. Why? They're greater than or equal to 4 millimeters. And you can see how big these are. Compare that to these. Would these be varicose veins? No, they're much smaller, right? So these are varicose veins in the pretibial, below the knee, calf area. And here are the reticular veins. You see these? These are 2 to 3 millimeters in size, and these are blue. And they can be associated with these teeny little veins, which are the spider veins, or called telangiectatic veins. And here they are here. These teeny little 1 millimeter veins. So when we go to treat these, we don't start by injecting here. We want to inject the hub. And in fact, we want to close where that reflux starts. We want to turn the hose off, or better analogy, or another analogy, we want to close the trunk of the tree before we close all the little branches. Okay? Because when you close the trunk of the tree, a lot of the branches will close as well. And then what's left open won't have as much pressure behind it, so you have a better chance of closing those. Can everybody in the back hear me?
Yes.
Okay. Any questions to date, to the point? Okay, we'll keep going then. So here's the anatomy I want to share with you. Now, I'm calling them superficial veins because they are, but you still don't see them. Okay, so these are the superficial veins that are not the deep veins. You don't want to get a blood clot, right? You've heard that, don't get a blood clot, don't get a blood clot. We're really talking about the deep veins primarily. You don't want to get a blood clot in the deep veins, which carries 95% of the blood in your legs. Those are here, these purple veins. And we work very hard to keep those open. The superficial veins are what I'm talking about today. They only carry about 5% of your blood, and when they're not working well, you don't need them to be just pooling blood. They're not doing anything for you. Those are the veins we want to close. So you can see here's a leg, here's a hip, here's the deep veins, and here's this great saphenous vein I was sharing with you on the inside of your leg. And remember I showed you that picture of the hairdresser who had all the disease down here? I showed you a variety of legs actually, and the disease was all down here. You can see how if reflux is happening in this great saphenous vein, which runs along the inside of the leg, you're going to see the disease and the changes down in here. Make sense? So if I'm going to treat this, I can't just do something here. I got to try and close as much of this as possible. But we do it through one teeny little hole right about there. Smaller than a freckle. Okay? And we wiggle, I'll show you pictures, but we wiggle catheters and wires and things up this vein, and on the inside we close it, and then we decrease the pressure, the hose that's giving you the problems down in your foot. Okay? The other one I wanted you to remember that was the great saphenous vein. This is the small saphenous vein. And this one runs behind the leg. Okay, so this purple is the deep vein, popliteal vein. We want to keep those open. And there's a lot of deep veins in the calf. But this superficial vein, the small saphenous vein, if it's not working well or it's giving you a lot of varicosities, oftentimes calf cramping, because again, the blood's going the wrong direction, we can close this vein as well. And by doing that, we turn off the main hose that's producing flow to the varicose veins. They will shrink up, and what doesn't shrink up, we can handle with 2 other techniques, which I'll share with you later. Okay, now, I've made it pretty simple, great saphenous, small saphenous vein. The reality is your venous system is very complex and complicated with a lot of backup plans. So even the calves in your leg, those deep veins, they're duplicated. You know, there's 2 anterior tibial, 2 perineal, 2 posterior tibial. There's a variety of backup to your veins. And that's what I'm showing you here. There's just a lot of different kinds of veins all over your leg. We really work hard to keep what we're trying to close in the area that we want to close, in the superficial system, and stay out of the deep system. So this is called the saphenofemoral junction. The femoral junction is a deep vein. The saphenous vein, great saphenous vein, is your superficial vein. And so when we're doing our ultrasound, we're looking really closely at this area to make sure our catheter just comes to this area here, and it doesn't get near the deep vein. That's why I need ultrasound to do it. So I can interrogate in here and make sure I'm in the right spot where I want to be. And There's a lot of connections between the deep and the superficial veins. There's things called perforating veins that communicate between the deep vein and the superficial vein. And then we call them varicose tributaries. Those are your varicose veins. And those are just between the superficial system and throughout your leg. So sometimes those perforating veins can be abnormal too, and we will close those. Here's an example. So here is your deep vein. Here's your perforator going between the superficial vein, the great saphenous, for example, or the small saphenous, or a varicose vein, and here's your skin. So blood should go through the superficial system into the deep system and up to your heart. But if it's not working properly, blood is going the wrong direction. This is serving like a sump. And so we close this, and then blood goes the proper direction. Okay, yes ma'am?
By close, so your blood finds another route. Your body kind of figures it out.
Once you close the superficial veins that are abnormal, yes, the blood goes a different way.
Now, does it put extra pressure on those new pathways?
No, right, good question. No, there's plenty of compliance to the system, and it's not a problem. In fact, it may even help increasing the flow in the deep system. Other questions? Yes, ma'am?
Back when you mentioned the skin being dry, I don't understand what causes the skin to be dry like that, the eczema you call venous
Well,
eczema.
the eczema is venous stasis, that the blood is pooling down there and producing too much pressure at the capillary level, and fluid can actually be leaking out, or the venous blood can just be putting pressure on the skin and can give you the stasis dermatitis, meaning the blood's not moving like it's supposed to and your body doesn't like that. And then the dry skin, the itchy skin, that's just the symptoms of what happens when you get the stasis. Okay? This is again just showing you those connections. So we don't understand why this exactly happens, but we do know that you can get this inflammatory response, weepy wounds, sores, ulcers, or you can get the dry bark-like reaction, if you will, to having too much blood pushing on your lower extremity. So some people just get swelling, some people get the venous stasis eczema, some people get the ulcers. Everybody has a different response. So this is how we start. If you have these symptoms, and I'll show you an example, a couple examples of our intake exam, you come for a clinical examination. And in that clinical examination, we ask you a bajillion questions about symptoms of vein disease. So we do a good history and look at your symptoms, and then we do a physical exam, we look at your legs. Because truly, by looking at the legs, oftentimes we can see abnormalities. Now, sometimes we're surprised. I had a woman come in to see me just this week with bilateral leg swelling, young, didn't see any veins. There's a million causes of swelling, so I really didn't think she'd have reflux, but we did the ultrasound and we were all surprised. She has a ton of reflux. So sometimes you don't see any varicose veins or anything. Sometimes you just have swelling. Other times you can have the big, fat, swollen legs that are purple and brown and all different colors. Everybody presents differently, but there's a million choices that they can have. So then we do our ultrasound, and we do it in the standing position and the laying down position. And we ask you to bear down and not. And we, we push on your vein and relax it, looking to see what's open, what's closed. And we're looking in real time because we want to see the direction of the flow. It's not enough to see if that vein is open or closed, like in the deep system. Do you have a blood clot or not? No. This, we need to watch how your blood is flowing. So we'll squeeze the leg and push it up, and then we'll see if it stays up. Because in theory, once you push it up, it should stay up, right? The valve should close. It shouldn't come back down. But if it comes back down, and it comes back down for a long time, longer than it should, that means the valves are not functioning properly, and that's how we decide if there's reflux or not. Okay? So our ultrasounds can take a long time to do because they're very detailed. But that's our roadmap, and that tells us how we can help you, how we can fix the problem.
Can I ask a question?
Sure.
What about pain?
Pain can definitely occur. Your legs don't feel good when they have too much blood in them and they're pushing, so you can definitely get pain. But there's different types of pain. We have certain sort of classic symptoms for pain in the legs, and I'll go into a little bit of that. But yes, pain is present, and some people are taking Advil, Aleve. pain medicine throughout the day because their legs ache so badly. Now, we can see, if you can imagine, with an ultrasound probe, you can see up to your groin, right? But how do you see deep into the pelvis? Because if you remember, your veins come up on both legs, but then they have to come together to meet, called the inferior vena cava, and then the inferior vena cava comes all the way up to the heart. Similar in the neck, the two arm veins come together, the neck vein comes together, it all comes together to form the superior vena cava. So the inferior vena cava and the superior vena cava come together, and that's how your blood gets to your heart, then to your lungs, etc., and gets oxygenated. So the left leg vein comes across and then meets the right leg vein, and together they go up as one vein with more things joining, kidney veins and other things, as it gets to the heart. Well, with an ultrasound probe, a lot of things get in the way when we try to look high. First of all, the IVC gets deep. Second of all, there's bowel and things in the way. It's harder to see. So sometimes if we have a suspicion there may be something else going on, we will order an MRI. Again, I'm the radiologist, right? So we do imaging and we're looking to see what's happening to that vein as it gets up on either side and meets the IVC. So on occasion, we do need an MR venogram to really finish the job of looking at the veins of the leg before we treat. Now here's that intake form I was telling you about. All the different symptoms of vein disease. So if you look here, you can see, have you had a deep vein thrombosis, clotting disorder, any problems like that? Family history. Remember, mother, father, 90%, 60%, or 20%, it makes a difference in terms of your odds of having the problem. What kind of medications are you on? Allergies, these things are all very important. And here are the symptoms. Date the symptoms began. Bulging vein, burning, itching, pain, heaviness. Here's your pain. See, pain's in there. Skin changes, cramps, eczema, spontaneous bleeding. Small story. I give these lectures not only to the community, but also to other physicians, internal medicine, family practice, etc., as well as my colleagues. You know, I'm at UCLA now, so I speak a lot. And I had a group of family practice physicians a couple years ago in the audience, and one guy in particular was asking a lot of questions, more than the usual group of doctors. I thought that was interesting. 6 months, maybe a year later, I get a call from him. Oh my God, I was in the emergency room this weekend. What happened? He was just scratching his leg and he had varicose vein. And it was bleeding so badly that this family medicine doctor was so upset and so scared he took himself to the emergency room. Anyway, they didn't do it, you know, just so you know, if you ever cut yourself a varicose vein, it's not a big deal. Lay yourself down, lift your leg up, put pressure. It's not an artery and the bleeding will stop. So let me just tell you, they're low pressure and it's easy to get it to stop yourself, but there was just so much fear because there was a lot of blood. When you're standing up, there can be a lot of blood. Anyway, long story short, he did become my patient and we fixed him and all went well. But you know, you can get spontaneous bleeding that is a problem and can be very scary, and it can even take you to the emergency room because it's that scary until you learn that indeed it's okay. Just elevate your leg and put pressure. But that's certainly a reason to close your veins, right? You can't have veins that are that vulnerable, that close to the skin, cause you that kind of fear, that kind of problem. So that is an important thing, symptom that we use to treat. Here's restless leg syndrome. How many times during the day do you have to sit or take a break because of aching, burning, cramping, etc.? And you'll be surprised. A lot of people with this disease will say 2 or 3 times a day. I don't have it, so you know, I don't feel like I need to sit and elevate my legs all day long. But people that do, they go to the mall here, and they'll walk the mall, and then at the end of the mall, they'll feel like, gosh, I just want to sit down and elevate my legs, you know, and then the legs will feel better. It's one way we tell, is it vein disease or artery disease or nerve disease? It's another lecture I give called My Leg Hurts, Why? And in that lecture, I explain the difference between artery disease, nerve, pain, and vein pain. And so as physicians, we were able to tell, do we think it's a vein problem, an artery problem, or a nerve problem? Because certainly all 3 can give you pain in your legs. So these are the kinds of diagrams we make. And remember, we shared the great saphenous vein. You see here, and this is red. So this is showing me that the great saphenous vein has reflux, and there's a lot of varicose veins, or we call them varicose tributaries, communicating here with this refluxing great saphenous vein. So I know if I go in here and I close this great saphenous vein, I'm going to close the trunk of the tree. I'm going to take away a lot of the pressure on those varicose veins, and then at the end I'll see what's left and see if I need to do more. Again, this is the back side or the other leg. It may even be the other leg, but oftentimes people do have mirror image disease. You know, same thing on both sides. It's one reason why we look at both legs. And here again, we have reflux in the great saphenous vein and reflux into some of those tributaries, and then we make a nice map here, and we actually measure the size of the vein, the time of the reflux, whether it's refluxing. And from these detailed maps, we're able to tell what we need to fix, how, we know how to apply our techniques, and we continue to do ultrasounds until things are really better. How do we grade people? Well, we have two main classifications that we apply. This is one, it's called the SEEP classification. So we look at the clinical classification, the etiology, the anatomy, and the pathophysiology, and we give you grades. So if you just have the little ones, remember, telangiectasias or spider veins, 1 millimeter. Reticular veins are 2 to 3 millimeters. So if you have those type of veins, you're a C1. But you can have those, and you can also have varicose veins. Well, that would make you a C1 and a C2. And how about if you have swelling? Well, now you're a 1, a 2, a 3. And then how about if you have either the inflammatory changes or the bark-like changes, the hard rock-like changes that I was talking about? Those would make it a 4. And how about if you've had an ulcer or you have an ulcer? Again, that's how we grade you. And then we look at why. Did you inherit it? Is it primary? Is it reflux? And this is how we mark you, if you will, and give you a grade. And we also want to know clinically how you're doing. You asked about pain. Well, on this clinical severity score, we want to know if you've had pain. If you can see the varicose veins and where they are. Do you have edema? Do you have the induration, the skin changes, some of the other things that are clinical symptoms of the vein disease? And we also want to know if you've tried compression stockings and did they help you or not. Compression stockings are fabulous. They make a big difference. And so we want to know if you've applied them or not. If you're bad, the higher ends of our grading system, if you will, a 4, 5, or 6, we can say you have chronic venous insufficiency. But for everyone else, we use the term disorder, as I shared with you before. So here's some examples. A C2, okay? This is going to have varicose veins. Remember that? 1 was the telangiectasias and spider veins. 2, varicose veins. 3, you see the difference in size? You're getting swelling. How about 4? You're getting the skin changes. And by 6, you're getting a real active ulcer in this area. Okay? And we really want so badly for people to be treated before they get these active ulcers. These are extremely painful. I have a lady now I'm treating who had 6 months of an ulcer like this. She had such a hard time walking. Young, active person, oh my goodness, went to 1 million people. We really tried a lot of things and nothing was working. And I got lucky, she came to me, and we were able to close a lot of the veins that were putting all that pressure on that area. And you know, it's only been 6 weeks and her ulcer is basically gone. And she said it changed her life. Because now she can walk, you know, she can move. She's lost 12 pounds. I mean, she's just happier, moving. We don't want people to get to this point. This is very painful, very bad, and there's just no reason nowadays why anyone has to get here. We want to catch people before they get there. Okay, this is the eczema. Venous stasis changes. Here's one of my patients, actually. She came, she was itching, 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 itching. Can you see all these changes here? You may want to come sit over here. You realize I'm kind of making a blind spot, but I don't disturb you. Whatever you like. So anyway, so here's the eczema. And again, great saphenous vein, we ablated. Small saphenous vein, we ablated. That means we closed. And then we took out some of these veins, and she did fabulously. Here's another ulcer. Artery disease can give you ulcers too. They give you dry ulcers, but vein ulcers, they're weepy ulcers. They're wet ulcers. And that's what you're looking at right here, a wet ulcer from vein disease. They're very painful. Okay, so what are our ways now that you know what the anatomy looks like? You know why you get it. You know how we grade you. You know how we do our workup. Now we're going to talk about how we treat you, how we make you better. So some of the techniques we use today, thermal ablation. Thermal means heat, ablation, close. Endovenous means from the middle of the vein. So we go into the middle of the vein and we heat and close the vein. We can use radiofrequency or we can use laser. They both work fabulously. Okay, data's At 5 years, well over 90% closure. They work terrifically. Anything we can close with heat, we want to close with heat because it works so well. Then phlebectomy, that's where we poke and pull. The branches that don't close with heat or they're so tortuous we can't use heat, we'll poke and we'll literally pull them out. But it doesn't require stitches or anything like that, just a small little nick, and we're able to go in and pull them out. And I'll show you some of the hooks I use to get rid of them. Sclerotherapy, that's where we inject with liquid to get veins to close. Compression stockings, we know how good they are, but most people don't want to wear them daily for the rest of their lives. Plus, actually, they can fail. You know, you can have bad disease, and though it's helping, it's not helping enough. So compression stockings are a treatment, but they're frequently not enough. And then we have some newer systems that I'm excited about. One is this chemical clarity vein, which I am getting ready to use of it. Glue-based systems, steam systems, there's a variety of new things coming, but the point is the same. We're just looking to close veins. Yes?
Is the thermal therapy hurt?
I'll share that with you, but no, to be honest. We have something called a visual analog scale, VAS, and we use it for a lot of things. If you've been to a doctor and you're talking about pain, we'll say, what's your VAS score? If you're in the hospital and a nurse wants to know, what's the level of your pain? It's the happy, sad face thing, right? So 0 is a happy face, and 10 is a sad, crying, screaming face. So 0 to 10, on average, if our patients grade the whole process of a procedure, they'll give it a 2. So, we're poking, like when you go to the dentist, we put numbing cream on the leg first if we're doing an ablation, but we're poking little needles, so that's uncomfortable, but like a 1 or 2, it's not a big pain. Sometimes after we close a vein, it can get sore, just that, but we give Advil and things to help with that pain. But it can be a little sore there, but it's not bad. Most of our patients that we treat do it with nothing, no Ativan or anything. They come to a clinic-like setting, lay down, we do the procedure. We walk a lot, doesn't get in the way of your life. We want you walking a lot, working the afternoon if you need to, it's fine. And there's a small percentage of our patients that are just more nervous or more sensitive because, we're born that way. And so for those patients, and I would say, and I'm guessing here, 2% maybe, they'll take Ativan or a Xanax, but you have to bring a driver then. And that helps a little bit. And I've only had one patient that I really had to knock out, and she wasn't anxious. She was just born with a different sensitivity. And we are born that way. So that's unusual. So, does that answer your question?
Doctor,
Good.
can you just go back to the other slide, previous slide for a second? The glue-based systems and the steam systems, those are all new?
Yeah, they're coming. They're things that we apply.
Okay.
Okay. All right, so endovenous thermal ablation. The systems that are tried and true that we're using today are RFA and laser techniques, and we usually do the great saphenous vein that you know about, the small saphenous vein that you know about. Occasionally there's something branches called the anterior and posterior accessory veins or the perforator veins. We put the cream on the leg as I talked with you about. It's a lidocaine-based cream, makes everybody more comfortable. Here I say 5% of our patients. Remember I said 2 to 5% with the Ativan, or I say 5 in my slide. But again, I'm guessing I have not done the analysis. And we advance the catheter up. This is what it looks like. The radiofrequency catheter has 7 centimeters of heating or 3 centimeters of heating, I pick. And the laser looks like this. This is a laser with heat at the tip, and we pull it back at a certain level. It does usually take us 30 minutes, more or less, to do a vein. Here's the machine. This is a radiofrequency machine, and this is the 7 centimeter heating element. Here we're prepping a leg. And here we're using ultrasound to guide a needle into the great saphenous vein, which is running on the inside of the leg. And I bet if I had asked you that, you would know that now, right? Because it's a vein on the inside of the leg. Here's the knee. I use ultrasound. I'm a radiologist. We use ultrasound. And I'm poking a needle. You can see a little bit of blood coming back at me, so I know I'm in the vessel. Then we advance a catheter into where we want, and then we use ultrasound at the groin. Remember that saphenofemoral junction we talked about? We use that to measure and make sure this is the deep vein. I don't want to be there. I want to be in the superficial vein and closing as much of it as possible, but staying safe. And that's what I'm measuring here. Then, once we have our catheter, I like to call it a piece of spaghetti, right? Because it's skinny and we wiggle it up. Once we have that piece of spaghetti up where we want it with our heating element right where we want it, we have to protect the adjacent tissues so we don't heat everything in sight. And we also want to smush that vein down on the heating element. So we inject water, saline, with a little bit of lidocaine and a little bit of bicarbonate to neutralize it all around that vein. So there's the catheter. Can you see that white dot? That's the catheter. This is the vein smushed on that element, and this black stuff is the water that's protecting all the adjacent tissues. So you're heating just the vein. We use a certain amount of lidocaine, and we limit that amount for patient safety. And this is ultrasound again, ultrasound machine, and a needle injecting that liquid up and down the leg around that vein. And here's the piece of spaghetti going through just a dot, closing that vein. Okay. And we leave you with a dot, usually smaller than your largest freckle. That's it. So laser we use at a variety of wavelengths. Laser technology is changing. We can't even describe just laser because there's so much detail to it. But laser, radio frequency, they both work fabulously in the vein. That's very different than the lasers you think about on the outside, like hair laser removal or any of that stuff. This is a different type of laser. Now how about phlebectomy? Once we've closed those trunkal veins, right, the trunk of a tree, and we've let the branches that are gonna shrink up, because they were communicating with the trunk of the tree, shrink up, we have a variety of other little branches that are left. What do we do with those? They're too curlicue, small, whatever to heat, so we poke and pull, and that's called phlebectomy. We just make teeny little incisions, we stick a hook in, and we pull them out. That's all, and then we put little bandages on them. They do extremely well. These are the different types of hooks we use. I marked here, this is my favorite, but it doesn't matter, everybody has their own hook that they like. Whatever will get the job done is the bottom line. It is like fishing, and I fished. So I made a little hole here, I went down, I found the vein, I'm pulling it out, I grabbed it, I'm just gonna pull until it's gone. And we can make a bunch of little hook lines, and they'll look like little freckles when we're done, and healing will occur. Patients like it a lot, it works very, very well. And here's a piece of vein that we've pulled out. It's an unfilled vein, that's why it's skinny and white instead of blue like on your hand. Okay, and how about sclerotherapy? You've heard about sclerotherapy, maybe you've gone to your doctor and had sclerotherapy. That's when we close the trunkal veins, we've taken out the bigger veins that are left, and now we just got those little ones basically, although we can do sclerotherapy for some of the deeper, bigger ones with ultrasound. In general, we use it for some of the superficial veins, and there's a variety of things we use. You may have heard of, let me get to this slide here. You may have heard of saline. You may have heard of a sclera, which is polydocanol, or you may have heard of sodium tetradecyl sulfate. Those are the three most common. Glycerin is sometimes used, but that's pretty rare. So let's look at their profile. Saline, which is commonly used. The good thing about it is you cannot have an allergic reaction to water, right? Can't happen. So that's the best part of it. The bad part is it causes necrosis. That's a breakdown of skin, an ulceration, a burn. That's not a good thing. And you can have more pain because of that. So we don't use saline. We like polydocanol, which is a sclera, because although you can have an allergic reaction to it, look at this profile. Ulceration, minimal, right? Just 1+, and pain close to 0. So it really is a wonderful drug. It was approved by the FDA March of last year, I believe, and we've been using it. We used to use sodium tetradecyl sulfate and sotradecol, we call it, and that too has a better profile than the saline, as you can see, but a sclera for this application is better for the smaller veins. We still use sotradecol, but we use it for our vascular malformations and for other things. So least painful is polydocanol or sclera and sotradecol. Least incidence of hyperpigmentation is glycerin, although I don't use it, it's rarely used. Least risk of anaphylaxis, that means an allergic reaction, that would be saline. And least risk of necrosis with extravasation, that means if I don't get it completely in that vein and it goes into the other tissues, the least risk is sclera, and that's why I like it a lot. Okay, I'm trying to accomplish a tough task. We've got these teeny little veins, I'm trying to close them. I certainly don't want to cause a problem. So that's why this is my first choice for liquid to inject. Yes?
Do you foam the polydocanol?
I do if I'm going for a bigger vein, not for the teeny little ones. It doesn't work well. So for bigger ones, sometimes I do, yes. Okay. So here we are injecting teeny little needles. We go down to a 32 gauge needle with a 3 cc syringe to inject some of those little veins. People always ask me, what about laser? What about laser? The reality is sclerotherapy works the best. But if you've maximized your sclerotherapy and you can't do any more, then there are some lasers, some radiofrequency devices that work. But they can produce pigmentation, hyperpigmentation. Now sometimes we use this technique, which is called a vein light. It's great. It transilluminates the skin and lets us see things that our naked eye won't let us see. And I use that a lot. I would say I use it almost for every sclerotherapy case, because if you have those little telangiectasias or reticular veins, I'm looking for the hub. I'm looking for the center, bigger vein. That's what I want to inject. And this transilluminator will allow me to do that. Here is your ultrasound-guided sclerotherapy. What we've done here is we use an ultrasound, and we can sometimes close bigger veins that we can't see with the eye, and because they're bigger, they can handle the foam, if you will. Complications, they're rare. We're always looking to make sure we don't get a deep vein thrombosis. We also want to make sure we don't get an allergic reaction, things like that. But they happen, but they're uncommon. We also want to try to avoid nerves, but sometimes you can get some numbness on the inside of your leg. That can happen, but we're very careful about the nerves. All right, so let's take some questions, and then I'm going to go through 1 or 2 examples, and then we'll be done. Yeah.
So in the scheme of things, then you're repairing these veins, and you're still subject to other veins becoming varicose,
Sure.
especially on a hereditary background, right?
Correct.
This is, so you can expect to maybe get more procedures in the future. I mean,
We say we control, we do not cure.
Exactly.
But you usually don't have more than one great saphenous vein and more than one small saphenous vein. So your body can look for other pathways, but once you get some of the big ones closed, you're usually doing pretty well. Sometimes we have perforating veins and other things down the road we need to close, but we're controlling you, you're doing well. We need to control you. Yes?
This is a related question.
Sure.
2.5 years ago, I had an external infection as a result of a wound in my leg, which infected badly, and was treated majorly with antibiotics and wrapping the leg and doing all of the necessary things up in Connecticut. There was pooling of blood around the ankle. 2.5 years later, there is still, it looks like I have a sunburn.
I understand.
Yeah. Does that ever go away, or does
No,
it?
it's like a
just stays
tattoo.
there? Yes.
It's like a tattoo. Some of the blood leaked out, and in your
Right.
soft tissues, you got what we call hemosiderin staining or staining, and up to a few years, I don't know the exact time,
Looks like a permanent
you
sunburn.
can have it fade. But after this amount of time, I would expect that it would be permanent, and it's just that the blood permanently stains you in a place where you weren't draining that well. Yes?
Yes, are there any contraindications? Do you
Sure.
not do someone's?
Sure. Well, first of all, that's a big question, but of course. because, you know, we have to always look at the big picture. You know, if something else takes precedent, that's a contraindication, right? It's not the priority. If someone can't walk, we're hesitant unless they have an ulcer. We wouldn't treat them because we really want you walking. There's a variety of things can get on our way. That's how we make that determination. Yes, ma'am.
Can medication create vein problems?
No, not that I know of, unless you're talking about a blood clot. So for example, if you have a blood problem you're born with, we call it thrombophilia, and you take, for example, hormone or birth control pills, you're more prone to clotting, you can get a blood clot. Or if you have a fracture and you get, you know, you're not walking and you're in a cast, you get a blood clot, that hurts your vein, that causes vein problems. But this kind of reflux without anything else happening would probably not be from something you did. Yes?
Can you talk about coverage, medical insurance coverage, with the different levels of varicose veins perhaps?
Sure. So as I'm sharing with you, this is a medical problem, not a cosmetic disease. And we're looking to treat people who have the medical problem, not the cosmetic problem. Insurances do recognize that, and so for patients that have failed compression stocking therapy, patients that have documented reflux that's significant, veins that have dilated that's significant, insurance will cover it. Not the deductibles, not the percentages, etc., but they usually will cover it because they recognize that patients are having the pain, the heaviness, the itching, the eczema, all those things that are medical problems. Yes?
2 questions. When one comes in for an initial appointment, do you do the testing then?
No, I do not. I personally do not. There are people out there that do. Okay. There are people out there that will do free consultation with a brief, put the probe on, etc. I don't. I'm more detail oriented than that maybe, and I take my time maybe, and I also like to go through a routine process of a complete physical examination, and then my ultrasound exams that we do at our facility are really detail oriented. So we don't do what you're describing.
And when you do the detailed process of
Yes.
examination and so forth, and also when you do treatment, do patients have to be off NSAIDs for a period of time?
No, not at all. Yes?
When would it be more beneficial to go to a vascular surgeon or a dermatologist to do these things versus a radiologist like you? Or is it better to just...
Well, there is some overlap. The vascular surgeons typically do the ablation like I would do. So that's a similarity, and they would do it similarly. They may use an operating room versus a clinic or whatever, but they do similar, most of them would use similar techniques. Most people do not do a surgery. Most people don't do a stripping anymore or a cut down anymore, anything like that. Some vascular surgeons who are in a vein center would do the complete. So they would take it all the way through the sclerotherapy. Others may not. They may only want to do the deep stuff by interest. Dermatologists similarly are more interested usually in the skin and not necessarily in the deep stuff, though there are some in again, vein centers who have learned how to do the deep stuff, but by training they don't learn the ultrasound. They don't learn the deeper technique. So I think what's unusual is that I do it all, and it's just because our training allows that. But there are plenty of vascular surgeons in vein centers that do it all, and dermatologists in vein centers that do it all. But typically they're more focused on the deep, if you're a vascular surgeon, and more on the skin if you're a dermatologist. Yes?
I've been taking horse chestnut for probably 20 years. What is your thought on that? I was told it's good for the veins.
I know, there are a couple of those things, and I don't know if any of it's been proven.
I didn't hear the first part.
She said she's been taking horse chestnut for a few years, and there is data to support that. So it's not thought to be crazy. I don't know enough about it, and I don't know if there's enough data to convince me that it's going to make that much of a difference, but I've heard of it and I understand. Yes, sir?
What is the financial cost for some of these procedures, what would we be looking at it as a financial obligation?
Depends on your insurance, and every insurance is different.
Well, I know the insurance is different, but I mean, because the surgeon would be billing
Right.
your medical
Yes.
plan.
Every procedure I've discussed has a different payment, and what we charge and collect is different based on every insurance. So I really can't be specific.
Well,
Most patients aren't paying full on cash, and again, the charges and the collections are different based on every insurance.
What if you're doing it for mainly cosmetic reasons and, you know, so then your insurance would not be paying? So, you know, I'd want some idea, like he wants to know what it would cost.
Okay. Well, first of all, I do a complete ultrasound. So you have a clinic visit cost, which at UCLA for me is about $150. Then if you have an ultrasound, I don't know the charges and the collections. They're different based on your insurance. I really can't tell you. I can tell you it's under $1,000 for the ultrasound, but what we charge is usually much more than what we collect based on your insurance. So does that give you a sense?
If you're doing, well, can you find out at some point what it would cost?
Sure. Sure.
How would
Again,
you-
it depends on what you need. So I think the consultation, the ultrasound is where you begin, and once you get that, we can tell you more specifically. I'm not really in the cosmetic business for cosmetic sake. I think there are other people that are, but we do sclerotherapy if needed, but only once we've cleared through a detailed ultrasound and made sure that there's no underlying reflux. And then we're very concerned with the cosmetics at the end, but that's not our main interest overall. Yes, ma'am.
You mentioned walking is a complete necessity, and I've
Yes.
also been told vitamin C to
Right.
increase the level of vitamin C in my diet, and she mentioned horse chestnut. Are there any steps that can be taken, activities, changes to diet that would strengthen
No.
walls?
Walk. Wear compression stockings and walk. Wear compression stockings. Let me finish the lecture if you don't mind, and then we will take more questions, okay? Because in the lecture I talk about compression stockings, and I would recommend that everybody, more than spending the money on the horse chestnut and the vitamin C, you spend your money on compression stockings. That would be my, and I can tell you those are about, they shouldn't be more than $25 a pair, and online you can get them for less, and I'll give you the strength that I recommend. When you're horizontal, you don't need them, but when you're vertical, you're fighting gravity, and you do. So during the day, instead of wearing socks, you should wear compression stockings, and you should walk a lot. Those are the two things you can do to really help the health of your leg and the vein health of your leg. Okay, so let me give you a couple examples here, and then we'll end, and then I'll take some more questions. So here's a wonderful case. It's a 40-year-old male with significant leg pain and discomfort. He had put off seeking treatment because he exercises 2 times per day, and he was told he would have to stop his exercise for weeks. When we reassured him that he would only have to take it easy for 1 week, that means treadmill walking instead of running, moderate pace on the bike rather than a vigorous pace, he decided it would be okay, and he signed up for treatment. So here are his legs. Now, this is a gentleman who hates going to doctors, would never want to go to doctors, but you know, he was really unhappy and really uncomfortable. So you can see here the big varicose veins on both sides. Can you see that? And you're going to say, okay, well, he probably has great saphenous vein reflux on both sides, coming down here, but what about the small saphenous vein? What about perforators? You can see how we really do need to do that ultrasound to understand his veins. Here's the inside of the leg. You can almost see a big dilated great saphenous vein that is refluxing with these big veins here, reflux and big veins here. And here is his history and physical form. Now this is a little bit of a doctor joke, so you'll have to bear with me, but we know when people just put little teeny marks here rather than big circles, that they really don't like going to the doctor and they're going to underestimate their symptoms, okay? It's just like having handwriting with people that make little nice print, you know, that's perfect versus the flowery print. If you're a flowery print person, you usually talk like I do with your hands and you make big things, but he really underestimated his symptoms, and He makes these little, both legs have burning, true. Both legs have bulging veins, true. Both legs are tired and cramping, true. He doesn't really elevate his legs, probably because he doesn't take the time or want to. And he's really not had any intervention, but he has had compression stockings. He's been trying it daily, and were they helpful? No. So this is a great example of someone who has really failed compression, and compression is not going to be enough. His father did have the disease, but other than that, he's very healthy. Here we graded him, and he gets a high grade, right? Because he has skin changes, and here we go. 1, 2, 3, 4, AS, symptomatic. And on his Venous Clinical Severity score, we graded him, and he's a 7. So here are his drawings, and now you can see why these are so important to me. Okay? So you can see, now you know the one that runs on the inside of the leg, it's called the... Yeah, I heard a grater, no grater back there. It's just great, that's old-fashioned terminology. Great saphenous vein, okay? So his great saphenous vein, not only is it refluxing, but has an aneurysm in it. I mean, it's big and not happy and dilated. And then he's got all these varicose veins. And I must tell you, my technologists that take the time and do this are phenomenal. They really are, and I'm very indebted to them because someone over here asked me if I do it at the same time, when I see a patient. I don't have the patience to do this. This takes a lot of patience and time and effort, and they really are spectacular. And I really give them kudos. So they make these spectacular drawings for me. And you can see there's reflux at the saphenofemoral junction. This valve isn't closing, and it goes all the way down to here, and then there's these big varicose veins coming off here. Even in the deep system, the blood is going the wrong direction. That's a pretty bad disease. And then he has these refluxing perforators as well. This is the other leg, and he has mirror image pathology, really, because again, this great saphenous vein is refluxing, and here are all these big varicose veins, and even in his deep system, he's got reflux. And here is his drawing with numbers. We measure everything, and you can see how large these veins are, abnormal. So we take our piece of spaghetti, our catheter, and we advance it to where we want it, and we heat the inside of that vein. We put our tumescent, now you know there's saline that we put all around that vein. We smush it on the catheter and we heat it to close it. And here's an after. Okay? Here's an after on one side and a before on the other. Here's an after, and here's an after. That was only 1 or 2 procedures. Okay? He did great. And here's a before, and here's an after. And I must tell you, ladies, please don't be offended, but I love treating the men. Why? They've got that fur, and the fur covers up any little holes I make. Seriously, it's wonderful.
Do you transplant fur?
But I must tell you, the men come, and they're so funny, because they can't figure out why they have this, and they all say, I think I got hit in the leg with a ball when I was a kid. Because ever since then, I've had this bulging vein, and I reassure them it has nothing to do with being hit in the leg with the ball. But anyway, their fur helps cover up any little dots we should make, but here is a dot here. Now he was interesting because he did get a complication that didn't matter in the end. But he, under it all, has what we call thrombophilia. We didn't know it, he didn't know it, but he's got a propensity to clot. So after our procedure, he got a little bit of blood clots getting into the deep system. We gave him Lovenox, because that's how we treat it, a blood thinner for 2 weeks. He gave himself an injection and it all went away and it was fine.
How do you know you have a blood clot?
Because I do an ultrasound after every procedure I do, 1 to 3 weeks later, and we look for that to make sure we don't. Okay, 1% of the time it can happen, and it tends to happen in people that have this underlying problem. He did great, but you can see here's the blood clot showing me some compression on that vein that I don't want, but 2 weeks later, it's all clear, deep vein's good, superficial vein is closed, and again, he did extremely well. This is showing you the closed vein. And here he is post. Looking beautiful, and he was able to go to the gym every day. and work. You know, I understand people that go to the gym every day, twice a day, but do they really work and support a family? He worked, supported a family, and still went to the gym twice a day. That's beyond what I can understand. He's more of a man than I am, what can I tell you? All right, so this was showing you that his grading system went down. His CEEP lowered, and his VCSF, which was a 7, is now a 1. So all these symptoms, the pain, the varicosities, the edema, all that improved tremendously. This is a person that doesn't underestimate their symptoms as much. You see the bigger dots and everything, but she really did have symptoms of psoriasis and skin changes. This leg is treated, this leg is not. You can see how so much of this has gone away and cleared up. Here are some of her drawings. We'll just go through those a little more quickly. And we did do some phlebectomy. We put in our sheath, put in our needle and our tumescent. And here we're doing, remember that little illuminating device? We used that to pull out the veins. See how I'm pulling out the veins? Nobody passed out on me. I must tell you, I did give a lecture once, and someone did pass out on me. I'm not sure I was the cause, and it wasn't held at a shopping center. It was at a like a convalescent home. But seriously, they passed out right into the hallway. We had to pause and call the ambulance. It was not pretty, so please don't do
You
that.
should make a recommendation like they do on Dr. Oz or the doctors that it may be sensible, you know, maybe sensitive to the audience. You may want to warn your audience.
That real stuff is coming?
Yeah.
Okay, then I'm a real doctor and this is real stuff. It's not all cartoon drawings. I have real pictures of it. Okay. Well, I don't see any children, so we're all right. Yes?
Did you mention that these patients are not under sedation?
None.
None.
None. Everybody does really well. And it's not that all my patients are brave. But we talk a lot and, you know, we laugh a lot and we tell you when it's going to hurt a little. It's just like when you go to the dentist. You always get sedated when you go to the dentist? No. Same kind of thing. We hurt less than the dentist, we think. And so I'm just going to finish up here and then I'll take any questions we have. Here are pieces of the vein what we pulled out. You see the little valves here? Those are the valves. And these are the teeny little holes that we leave you with. We put little steri strips on and you heal up beautifully and all is good. So this is the last slide and this is the follow-up care. So this is showing you how important compression is. When I do a procedure, you do have to take an NSAID. Some people that do this work don't put patients on NSAIDs, and that's fine too, but then a certain percentage will get the painful phlebitis, inflammation. If you can tolerate it, I like to give an NSAID and just avoid that whole process completely. So we keep everybody very comfortable, but for 10 days or so, we give you NSAIDs. And then we ask you to wear your compression stockings for 2 days, day and night, and then depending on what we do, you wear it during the daytime, which means when you're vertical. This week I did have, or last week actually, a night nurse. So I had to clarify, it's not, you wear them in the daytime and not at night. I had to say, no, you wear them when you're vertical, because she was working at night. So you wear them when you're vertical to fight gravity, and when you're horizontal, you don't wear them. And that's for 1 week for just phlebectomy today. I can change it tomorrow. 2 weeks if I've done a heat procedure, and 3 weeks if I do sclerotherapy. Because closing those little ones is, believe it or not, harder than closing the big ones. And if you want to do something healthy for your legs, and spend 20 bucks or so on it, compression, this is what we like, 20 to 30 millimeters, they're firm. As long as you can tolerate them, that's what we prefer.
I wear them when I travel on airplane.
That's great.
But usually I do not, but I do sit wherever I sit in that
Got it. Okay, questions?
Okay.
Yes, ma'am.
Is edema a result of poor veins?
Can be. Can be a variety of things. It can be your heart not functioning well. So if it's backup of the venous system, then that's usually both legs, or it can be the veins on one leg or the other not working well. So yes is the answer, but there's other things too. They shouldn't be $65, and that's why I'm clarifying. CVS, Walgreens, they have them. Look online. That's why I give that price. 20, 25 should be about what you should spend. We like 20 to 30 better, but you know, if you're wearing them, fine. Some people can't tolerate 20 to 30, so if you're wearing them every day and 15 to 20 works for you, it's better than nothing. But 20 to 30 is what we usually recommend. And again, you can have a lot of choices for what makes your legs swell, but one of the choices is vein disease. It is one of the choices.
And do you think this procedure would help it?
I don't know what you have.
Oh, okay, so that I have to see.
You have to first figure out what you got.
Is there an age criteria where you say,
No.
live with it?
No, today I just saw an 87-year-old man I treated. He is so happy. And I've also treated a 17-year-old girl who ran in sneakers to her last appointment. She was so happy. She'd stand up every day and have purple legs that would ache and ache and ache. And her mother was like, this is weird. She took her to me and we did the ultrasound and we were surprised. She's my youngest so far, 17. She had terrible vein disease. I did 3 heating treatments on her and her legs are so happy and her ankles are so happy and she feels great and she could not be happier. So no is the answer. As long as you can walk and feel healthy, it's fine. Yes.
When you say stockings, you mean the full to the waist things? Or?
No, I mean to the knees typically for daily, what can I do instead of your medication.
I mean, like,
when I do a procedure, I put you into the thigh because I'm treating up to the thigh. But in terms of a lifestyle change, compression stockings to the knee are terrific.
Okay, so if we have like leftover TED stockings?
No, they don't count. That has no compression. You want compression stockings with 20 to 30 millimeters of compression. TED hose is not. Yes, ma'am.
Compression stockings, just if you're having pain, what if you just don't like the look of the spider veins?
If you're having pain or itching or heaviness or any of those things, and oftentimes it goes along with I don't like how they look, then we should treat you and do an ultrasound and just see what's happening. But sometimes it's just the beginning and we need to look.
No, compression stockings, are they for anything, just for appearance? If you're not having any pain, no swelling, no discomfort, you just don't like the look of the spider veins?
You can consider wearing compression stockings. Yes.
Over 20 years ago or so, I had the saline done, and I also had my veins stripped. And now I've got varicose again. Do you think it wise that I look into it again?
Yes, because by definition you have the disease, the disorder, and other things are happening, and you had swelling, so it's worth controlling. Remember, we control, we don't cure. You were controlled 20 years ago with contemporary techniques. We've evolved, and now you probably need control again.
Okay.
So I would get updated.
Yeah. Okay.
And 20 years from now, I'd get updated again, because more will come.
Yes. Okay.
Yes, ma'am.
Would, like, if a person had, say, diabetes or collagen vascular disease or, say, lupus, the man that you talked about with the clotting disorder that you didn't know that he had,
yes.
If you had known that prior to him having his procedure, would you have said, no, I really can't?
No, I would definitely treat him. I would have just put him on Lovenox to begin with.
And what about, like, say, the collagen vascular or autoimmune? I mean,
No
does
problem.
anything?
Yes. No. With diabetes, I always worry a little more about infection. It's one reason why I would tend to keep you more on the NSAIDs, keep the phlebitis down, because sometimes the phlebitis, the inflammation can look like infection, and that would scare me. So if I can keep your inflammation down, then if you turn red, then I know you have an infection, right? You know, I'm trying to keep it simple. But no, we treat people like that. We're very careful with pulses. We may not go too low. We don't want wounds too low where you may not heal. I'm an interventional radiologist, so I deal with arteries all the time, and I understand that anatomy. You know, when you're a diabetic, if you get a sore in your foot, you won't heal it as well, partly because your arterial system has become much smaller. And you don't heal as well, so we may change where we put our wounds, but we would still close you because in theory, if I'm treating you, your symptoms are bad enough that you're swelling and having other manifestations that we want to get rid of. It's worth it. Yes, ma'am.
So with the tights and the compression stuff, I'm definitely feel different. My body feels different as well. Compression from the just plain tights.
Oh yeah, huge difference. Yes, with tights versus compression make a difference. And compression will make your legs feel much better. Tights may not.
And do you become dependent on that?
No, it just helps. Helps tremendously. Yes, sir.
How do you prevent possible blood clot during the treatment and after the treatment?
One more time?
Blood clot.
Yes, what about a blood clot? When I worry about it?
This thing?
How do I prevent blood clots from the treatment?
During the treatment and after the treatment.
Well, during the treatment, I'm careful where I put my catheters and things. But I do inject liquids that go everywhere. So getting you up and having you walk is what flushes out the deep system and helps. Those are the kinds of things we do to decrease that risk. Yes.
I've read that the the newer laser systems are actually in long term, they have better outcomes than the radio frequency. And then the newer ones are like the 1470 because they use less energy. There's a lot less pain and bruising. Are you using those?
I have the 1470. I still don't use it as regularly. And actually the long-term data on 1470 is not out. You don't have any 5-year data on that. We've been playing with what the amount of dose density is with the 1470. You know, there's the 810, 980, there's all different kinds of lasers. And they all work very well. It's just about the dose density. And we're still working that out. But no, it does not take precedence or is better. It's as good maybe, but it is not better. The radio frequency actually had data showing that it is less painful than laser. Now the 1470s come along, we wonder, but it has a lot to do with the dose density. If you don't give enough, it may not hurt as much, but it may not stay as closed, and we don't have 5-year data yet. You can buy any kind you'd like. They come in all sizes, all styles, any kind is fine. Whatever works well for you is fine. Yes, ma'am.
When your veins are more cosmetic rather than painful or bulging, do you think it justifies having an evaluation? Is there, if you aren't having pain, is that
it could
an
be
indication that this is more of a minor problem and don't
It
worry
depends.
about it?
What if your mother, your father, your sister, everybody has them, and you now know that you have a 90% chance of having more than you think you have? Then it's worth having an ultrasound and a full evaluation. If nobody in your family has it, you're not really bothered by it, you just think there's a few veins there, then maybe it's not worth having a full evaluation. So there's a variety of factors that make us decide. I'm pretty liberal with the ultrasound because it doesn't hurt you, and it really gives me the real answers, and then I can know where to go from there. Yes?
2 questions. One is about certain companies you recommend for the compression stockings.
I don't. I do not have a preference.
Okay, and the other, so one company, if one makes it, they all make it for rather
Yeah, if it feels good to you, it's fine.
Well, you don't
the
know
price is right and it feels good to you, it's fine.
well,
But the number I care
about. You don't
about.
know if it feels good to you unless you buy it and wear it. So. And the other question is the difference between spider veins and varicose veins. What if someone has a lot of spider veins, but they may or may not have varicose veins? Do those two intersect in terms of a visit to your
You may not have been here when I showed the one slide with how you can have the spider veins communicating with varicose veins. So you can have underlying varicose veins that are communicating with the spider veins, and they can be related.
The only way to find out is the ultrasound.
Yes, ma'am.
Okay. So will it be swimming as well as good as walking?
I don't think you're contracting your calf as well as with walking. So I don't recommend the elliptical or swimming, I recommend walking. Running's good too. All right, thank you everybody.
Thank you very much.